Yeah, good afternoon to all. I thank the organizing committee for giving me this opportunity. So I'll be talking on early intervention strategies. So vision is a product of the complex system in which eyes are a part. 40% of the brain is involved in the visual function. So CVI is nothing but it's a form of neurological visual impairment that is caused by dysfunction of the brain rather than a disorder of the ocular system. So anything that is posterior to the lateral geniculate, retrogeniculate visual pathway results in CVI, and pregeniculate, we term it as an ocular visual impairment. Briefly, I'll be talking about the cortical visual impairment because the next session is going to be in detail before going into the early interventions. So recently, CVI has been the most common cause of visual impairment in children. Mostly it is left unobserved and underdetected. In the developing countries, recently because of better management of the avoidable cause, improved diagnosis and reporting, and increased survival of premature infants, we are seeing the incidence to be rising. So the most common cause of all these lists is hypoxic ischemic encephalopathy followed by neonatal hypoglycemia. So these result in periventricular leukomalacia. The other reasons are epilepsy, focal brain lesions, injury, infections, malformations, metabolic and genetic causes. So based on the severity, that is the impact on the visual function, CVI is divided into severe, moderate and mild. So spectrum wise, those children who have profound visual impairment are classified and grouped as low functioning CVI, and those with normal and near normal visual acuity, who are the group most often missed, who have a cognitive visual dysfunction, are graded as high functioning CVI. How the brain sees, just in a brief. Whatever the visual impulses that are received from the brain are passed on to the occipital lobe. From there, via the dorsal stream, the informations are shared to the posterior parietal lobe, which is involved in 3D vision function, visual guided movements, and via the ventral stream shared to the temporal lobe, which is responsible for recognition of face, object, and routes. So if there is an occipital lobe injury, that results in poor vision, color, and the fields are affected. If there is a dorsal stream damage, it leads to optic ataxia, apraxia of gaze, simultagnasia, and lower visual field defects. If there is damage to the temporal lobe and the ventral stream damage, leads to visual agnosia and difficulty in seeing people and difficulty in recognizing routes. Middle temporal lobe damage results in difficulty in seeing fast moving objects, and intact middle temporal lobe with occipital lobe damage results in blind sight. So the workup starts with a detailed history followed by refraction, a proper examination of the accommodation of the child, anterior posterior segment evaluation, and the orthoptic evaluation. So history, you ask series of questions to actually trigger the evidence of vision. If there is evidence of vision, then you ask the further questions to the parents to know more about the details of vision. If in the history you are getting answers of negativity that there is no or limited vision, go to the parents further questioning about any possibility of vision, such as the child moving the mouth towards the side of the spoon when it is brought, or occasional reflex smiling, or tendency of light staring. So the intervention strategies, most often after a clinical evaluation, the intervention strategies for children would emerge from the clinical evaluation that is being made. So careful assessment is required. The assessment has to be in all the visual dimension of the aspects, such as visual discrimination, spheres, visual field, contrast, color, saccades, visual latency, and visual attention. There are series of tests which is in the armamentarium CVI, but one has to keep in mind that it is not possible to administer all the tests for a child in the first consultation. Most commonly, they undergo a preferential looking test, puppet face, mirror test, visual field, and color test, so as to know what the grade of the vision for the child is. So this here, we have a child who is undergoing functional vision assessment using a hiding Haydey low contrast test and a LIA paddle. It is quite challenging for the examiner and also for the parent to make them sit for the examination. So it gives us an idea. So where the child fixates, sometime momentarily only you will be getting a clue about the grade of the vision for the child. This is a LIA mailbox test to see for visual spatial orientation for this child. Here you can see that the child is keenly watching and able to fixate, but his coordination, spatial orientation is less. You can use it for direction wise also. It can be left held in the horizontal and vertical position. So after the clinical evaluation, many times many children with CVI may show little or no useful vision, but developing visual consciousness and appreciation of visual informations are the critical things and first step for intervention. One has to keep in mind that each child with CVI is unique and no one plan fits all. So the first thing to be tried is try glasses. Glasses are must. So there's a common notion that children with CVI do not accept glasses, and it's very difficult to prescribe glasses for them. But even if the refraction is going to be normal, prescribing a low plus such as +2 to a +3 or +5 will help them to perform the interventions in a better way. So perform a cycloplegic refraction and a MEM refraction, and wherever possible, try to give them glasses. The general principles for intervention: when once a methodology of intervention is planned for the child, prepare the child for that intervention. Posture is more important, especially in children with cerebral palsy. Having a positioning chair to keep the child, or else most of the time you'll be spending in positioning the child. Priming the child for the quality of object is also important. Using a radio language, one word at a time, not to use jargons of word, not to use sentences, to be very clear what we are trying to express to the child. Always insist on looking behavior. Communication is very important to keep the child always into the spectrum of training. Never to leave a child in a cradle unattended. Always it is better to continuously interact with them as part of the intervention. Environmental modification, like setting up a sensory tent or a place where the child will be much more calm to receive the interventions. So some suggestions are: start with a simple object that is available at home, what they have and what the child is familiar. It can be just 5 to 10 minutes when they start. It can be creative. It should be something that awakes the child's visual curiosity. You can use variety of object. Here the child is preferring a gaze. So always start the intervention from the gaze the child is preferring. And multisensory learning is the other aspect. Whenever the brain loses function in one sense, it tries to improve with the other sense. There is a strong link between the vision and touch. So this is a vision, it's a light box with a moving target that is given to the child. So one should keep in mind that strategies must be consistent with the child's and family's daily routine. It should not be something very different that they have to adopt specifically. So early intervention for phase 1, you can use an illuminated toy. You can use bright colored toys in a dark room using tactile stimulation. In phase 2, sibling play. Sibling play has a very big role. Mirror activities, daily activities can be converted into therapy. When in sibling play, basically it takes off the stress from the parents. When the siblings are being involved, the whole family should take up responsibility for the intervention for the child's aspect. For high functioning CY, we can use different puzzles, games, shapes and color matching. This is a sensory tent. Parents can do it at home. They can have a table, they can have a sheet put over the table and convert it into a sensory tent. It basically creates an environment of clutter-free, makes them more comfortable with the caregiver, and helps them to comply better. You can always display it to the parents, but always make sure that you convey it clearly to them. That should not create a clutter. This is just an idea for them to have what all items they can have. The most important thing is not only the vision therapist, there should be a good communication between the OT, physiotherapist, speech therapist, and the special educator. They should all be in one line so that the therapy goes for a long time and be successful for the child. So our role as the clinician should be to empower the parents for the strategies of their own. You can administer the CVI questionnaire so as to know which track the child is on. Questioning the parents and having a feedback will know where the parents are interested and where they are lacking behind. Because parents are the most important people who can optimally teach and communicate with their children. Few cases I want to share. This is a child brought at 2 years of age, full-term normal delivery. Child had seizures at 1 month of age. MRI brain was normal, and on doing a Lia paddle, she was responding to 1 cycles, and we started intervention for her. Her color vision we had tested. She was responding slightly more to the yellow intensity compared to the red. Then slowly her interventions at home were started. Parents were able to comply. So a familiar object that was used at home, which she often has, that was given, and you should give time for the child to observe. There should be a good distance. The positioning of the child is to be maintained always. Good illumination should be there. You should avoid any clutters. So here the mother is trying to give a glittery object. Usage of glasses, complying to that. Sometimes it is difficult to make them sit for a longer duration, so you can give gaps for them in between their interventions. This is a 3-year-old child who was brought to us. She had a neonatal sepsis and delayed milestones. She was only responding to high contrast. She had a progressive encephalopathy. Her Lia grating was only 0.25 cycles. So the parents understood the degree of visual acuity that she had and was able to use things that were at home, they were able to be creative. So sometimes in such children, it is a little bit of frustration from the parent side when they show slower improvement, but as clinician, we should be able to encourage them for a continuous therapy. This child was brought at 2 years of age with a respiratory distress. His MRI showed PVL changes, alternative exotropia. Fundus showed a disc pallor. Parents were able to initiate therapy at home. He had fixing and following when he came. And slowly with therapy, with the objects that were at home, and parents were quite encouraging also. So here he has spatial orientation and difficulty. Slowly that improved. Mirror play also has a very good role, because they are able to see themselves, feel about the parts, interact very well, and be more expressive. This is a case for 6-year-old boy who had neonatal hypoglycemia, disc pallor. We prescribed hypermetropic glasses. His main problem was spatial relation and contrast. He was a high-functioning CVI child. Slowly, simple tips were given at home. He was able to comply. Parents were more encouraging. He started reading and writing. So here you can see that the parents are using a darker background, dark-colored pencils, and now his skills for reading, writing is slowly improving. This is a case 5. Again, this child is also a high-functioning CVI child who had febrile seizures, disc pallor. With the hypermetropic glasses, he was able to perform his reading skills, writing. And here the trainer, she's using a dark background with the text. So all these materials are brought by the parents. They become more creative and more involved as we start giving them the right directions. So when we looked into literature, what the literature stands for, the researches that go into CVI, this is published in 2023. So only there are 23 articles that were included in the study, and most of the research articles that look into intervention for CVI is still in its infancy, and lower level of evidence is there, and most of the studies have a smaller size. So that explains to us. So to take home points for my conclusion, each child with CVI is unique. Intervention strategies should be tailored based on the clinical evaluation. The caretaker must ensure that child's routines are filled with information. Thoughtful and proper interventions are required, and interdisciplinary measures will help us to give a successful therapy for these children. Thank you so much for your kind listening. Thank you, madam, for this opportunity.